Welcome to the deep dive. Usually when we talk about a medical diagnosis, there is this like underlying expectation of precision, right?
Oh, yeah, absolutely.
Yeah.
We treat the human body a bit like engineering.
Exactly. Like you fall off your bike, you break your arm, and the x-ray shows that jagged white line, and the doctor just points at it and says, well, there it is.
Yeah, it's entirely binary, like broken or not broken.
Right. It's clean.
Yeah.
And most importantly, it's visible. But today, we are stepping far away from that clean, visible world. We are taking you on a deep dive into this totally hidden microscopic battlefield inside the human body.
And it is a fascinating one.
It really is. We've got an amazing stack of sources in front of us today. We're looking at cutting-edge oncology research papers from the Frontiers Journal's Translational Cancer Reviews. And our mission today is to explore a biological risk that genuinely sounds like the plot of like a science fiction espionage thriller.
It really does read like a spy novel when you get into the actual molecular mechanisms.
Oh, yeah. It's wild. So imagine for just a second a tiny rogue construction crew secretly building a complex highway system inside your body.
Right. Totally undetected.
Exactly. And they are doing it specifically to funnel nutrients to a threat you don't even know is there yet. We are talking about undetected precancerous lesions, specifically in tissues like the cervix and the vulva.
It's a critical area of study right now.
So we are going to look at how these tiny clusters of rogue cells use microscopic messengers called exosomes to secretly build their own blood supply, just completely under the radar.
Yeah, and to help you visualize what we're actually talking about today, let's look at the backdrop behind me. It is displaying this dynamic, glowing map.
It looks incredible, by the way, like a city grid.
Yeah, but rather than just looking like a satellite view of a city at night, I want you to look at it as a real-time logistics network. You're seeing complex cellular networks and glowing blood vessels, just pulsing with activity.
It's constant movement everywhere.
Right. This is the microscopic metropolis we are exploring. It's a highly regulated, tightly controlled supply chain where resources only go exactly where they are needed. And today, we're going to look at exactly how that pristine supply chain gets hijacked.
Okay, let's unpack this, because before we can understand how these precancers build their rogue blood vessels, we have to understand the vehicles they use to send their instructions in the first place. You called them exosomes. What exactly are we looking at when we talk about an exosome?
Well, when you look at an exosome under an electron microscope, it basically looks like a tiny teacup-like blister.
A blister.
Yeah, and cells secrete them naturally all the time. And when I say tiny, I mean incredibly small.
Right.
We are talking about maybe 30 to 150 nanometers in diameter.
Wow, so that's, I can't even visualize that.
To put that in perspective, you could fit millions of them on the head of a pin.
Millions on a pinhead. That is insane.
Right. But despite their size, they are incredibly durable. They are formed with a phospholipid bilayer.
Which is essentially the same, like, tough, fatty membrane that surrounds our actual cells, right?
That's the one. It is a very robust outer shell.
Yeah.
And inside these little protective bubbles is a payload. For a long time, we didn't fully understand what they were doing. But now we know they act as a highly targeted cell-to-cell transit system.
Okay, so they're carrying something specific.
Exactly. They carry molecular blueprints, things like DNA fragments, proteins, lipids, and a very specific type of cargo called non-coding RNAs. In the research we're diving into today, you'll see constant references to LNCRNAs, which are long, non-coding RNAs, and miRNAs, or microRNAs.
Okay, wait. Now, if I'm remembering my basic biology correctly, raw RNA is incredibly fragile, right? Like, if you just injected loose, naked RNA directly into the bloodstream, it wouldn't make it very far.
Oh, it wouldn't make it anywhere at all.
Because the body has intense defense mechanisms, right? Like ribonuclease enzymes that patrol the blood, and they would just chew that RNA up instantly.
That fragility is exactly why the exosome is such a brilliant biological workaround. The exosome acts as an impenetrable protective shield.
Because of that fatty layer.
Because it's wrapped in that tough fatty layer we mentioned, it keeps the RNA cargo perfectly safe from degradation by those ribonuclease enzymes.
Oh, wow.
Yeah, so the genetic information remains completely stable, and it can travel massive distances through the body's fluids, whether that's blood, saliva, or urine.
So to put this in terms you and I might use every day, exosomes are essentially encrypted microscopic flash drives being passed between cells. Like, they're designed to sneak past the body's biological firewalls completely unnoticed to deliver their code.
I like that analogy. And if we connect this to the bigger picture of medical history, discovering this function was a massive paradigm shift.
Really? How so?
Well, when exosomes were first discovered decades ago, scientists literally thought they were cellular garbage bags.
Garbage bags? You mean like just throwing away waste?
Yeah, they observed cells pinching off these little bubbles and assumed the cell was just throwing out the trash. But now we realize they're arguably the most sophisticated communication devices in the human body.
That is a huge leap from garbage to sophisticated communicators.
Right. They can travel to a neighboring cell, or they can cross massive physiological blockades like the blood-brain barrier and completely reprogram the behavior of the cell that receives them.
Okay, so we know how the message is sent. We have our microscopic encrypted flash drives. But why does a precancerous lesion, let's say a tiny cluster of abnormal cells in the cervix, which the sources refer to as CAN or cervical intraepithelial neoplasia, why does it need to send this message in the first place? Like if it's just sitting there, what triggers it to start communicating?
It comes down to a harsh reality of physics, honestly, the diffusion limit.
The diffusion limit.
Right. A tumor, or even a very early precancerous lesion, cannot just grow indefinitely on its own. It is completely limited to a maximum size of about 1 to 2 millimeters.
Sure, 1 or 2 millimeters. We are talking about something literally the size of a pinhead.
Precisely. At that tiny size, the cells in the dead center of the lesion are now too far away from the body's existing blood vessels to get oxygen and nutrients.
Oh, so they're cut off.
Yeah, because normal cells get what they need through simple diffusion. Oxygen literally just seeps through the tissue. But oxygen can only travel so far. So once that cluster of rogue cells hits that 1 to 2 millimeter wall, the cells in the middle start to suffocate.
They just run out of air, basically.
Exactly. They experience a state called hypoxia, which is severe oxygen starvation.
Wait, let me push back on this because logically this feels like it should be the end of the story. Like if you starve a plant of water, it dies. If you starve an animal of oxygen, it dies. If these rogue precancerous cells are suffocating, shouldn't they just wither away and die off? Why does choking them out make them more dangerous to you?
It is a totally logical assumption, and it highlights just how terrifyingly resilient abnormal cells can be. Instead of quietly dying off the lack of oxygen, triggers a severe panic response.
A panic response?
Yeah, the hypoxia activates specific proteins inside the struggling cell called hypoxia-inducible factors, or HIFs. You can think of HIFs as a biological emergency alarm.
Okay, so the alarm goes off and then what?
When that alarm sounds, it forces the starving cells to frantically package and secrete exosomes packed with survival instructions. This specific panic event initiates what oncologists call the angiogenic switch.
The angiogenic switch. Angiogenesis meaning the biological process of creating new blood vessels.
He's got it. The cells forcefully kickstart the creation of a brand new customized blood supply to feed themselves.
That is just wild.
And in the context of our sources on cervical and vulvar precancers, flitting this switch is the definitive hallmark feature. It is the moment that marks the dangerous transition from a low-grade, relatively dormant precancer to a high-grade, highly threatening lesion.
Okay, so this brings us back to our rogue construction crew analogy. Once that starving precancer hits the panic button and releases these exosomal flash drives into the surrounding tissue, they float over to the healthy blood vessels nearby. And they essentially bribe the body's local construction workers, the endothelial cells that line your blood vessels, to start building new roads leading straight back to the tumor.
Let's look closely at how that bribe actually works when the blueprints are unpacked. The exosomes physically fuse with the healthy endothelial cells and drop their corrupted genetic code inside.
Just sneaking right in.
Yeah, and instead of lifting off all the complex alphanumeric names of these RNAs, let's focus on what they actually do to the cellular machinery. For instance, some of the RNA cargo specifically targets and suppresses a protein called vinculin.
Vinculin, what is its normal day job? Like, what does it usually do?
Think of vinculin as the molecular mortar between bricks. It is crucial for cell adhesion. It keeps the endothelial cells sticking tightly together to form a solid leak-proof pipe.
Okay, so it seals the pipes.
Right. But the tumor's exosomes tell the cell to stop making that mortar. And at the same time, the exosomes deliver other signaling components, like the hedgehog GLI pathway, which essentially jams a brick onto the accelerator of cell division.
Wait, so the local construction workers are multiplying wildly, building new roads at breakneck speed, but they have absolutely no mortar to hold the bricks together?
Exactly. And the result of that corrupted blueprint is the ultimate biological risk that we need to underline for anyone listening.
Okay, let's underline it.
Normal blood vessels are tightly woven, highly structured pipes. These new tumor-induced blood vessels are a chaotic mess. They are disorganized, they are twisted, and because they lack that structural mortar, They are incredibly leaky. They are like a soaker hose in a garden.
Here's where it gets really interesting, right? Because going back to our analogy, the roads are unpaved, tangled, and full of massive potholes.
Exactly. And those potholes provide a wide-open physical highway for the precancerous cells to eventually slip right into the bloodstream.
Oh, wow. So the leakiness isn't just a byproduct, it's a huge problem.
The leakiness is the very mechanism that allows a localized pinhead-sized problem to escape and become distant metastasis.
It's a horrifyingly efficient system. But if they are building these leaky blood vessels to steal nutrients, are they hijacking any other local infrastructure? Like, do the exosomes target anything besides the blood supply?
They do, and it is arguably just as devious. The exosomes also corrupt the local lymphatic system. They stimulate the creation of new lymphatic vessels, a process called lymphangiogenesis.
Okay, so they're hitting the lymph nodes too.
Yeah, but here is the truly sinister part. The specific RNA they drop into the lymphatic system actively impairs CD8 positive T-cell immunity.
The killer T cells, the body's natural defense force.
Right, so not only is the precancer building an escape route through the lymph nodes, it is simultaneously blinding the immune system's frontline soldiers. It creates a localized zone of immune evasion, allowing the tumor to operate with total impunity.
Unbelievable. So we know these leaky highways are being built in secret, and we know they are blinding the immune system while they do it. But where is this actually happening in patients today? Like, if we step out of the molecular world, what does this look like in clinical reality?
We have to look at specific tissues.
Right, let's look at the tissues where this covert operation is posing the most immediate threat right now. The research focuses intensely on CIN's cervical intraepithelial neoplasia and VIN vulvar intraepithelial neoplasia. Let's dig into VIN because the data surrounding it is just staggering.
It is. VIN is a non-invasive precursor to vulvar squamous cell carcinoma. And clinicians categorize it into two distinct types, both of which are seeing some pretty alarming trends.
What's the first type?
First, we have UVIN, or the usual type. This type is strongly linked to high-risk HPV infections, primarily HPV-16. And what stands out most starkly in the epidemiological data is the demographic shift we are seeing in real time.
A shift in who is getting it.
Exactly. Historically, the average age of onset for UVIN was around 52.7 years old. Today, that average has plummeted to just 35.8 years.
Wow, that is a drop of almost 2 decades.
Yeah, it's massive.
We're talking about a condition that was historically a postmenopausal concern, suddenly becoming a reality for women in their mid-30s. I mean, that is a massive shift in how we have to think about screening and early detection.
It completely changes the clinical landscape. And while UVIN is concerning the second type of DVN, the differentiated type is what really keeps oncologists awake at night.
Yeah, the sources mention that one.
This type is HPV independent, meaning a virus doesn't cause it. It's rarer, but the sources make its threat level very clear.
The numbers in the stack are terrifying, honestly.
They are. While UVIN progresses to invasive cancer relatively slowly, DVN has a staggering 32.8% risk of progressing to invasive carcinoma.
Wait, 32%?
Yes. But it's not just the likelihood, it is the speed. The time window for that progression averages just 22.8 months.
That's less than 2 years.
You are looking at less than 2 years from an undetected precancer to a fully invasive carcinoma.
How is that even possible? I mean, how does a lesion with a 30+% chance of turning into cancer in under 2 years just hide in plain sight? Why isn't the body throwing every alarm bell it has?
It loops right back to that immune evasion we touched on earlier. But the mechanics of it in VIN are fascinating. Normally, your immune system relies on mature dendritic cells. You can think of dendritic cells as the scouts of your immune system.
Okay, the scouts.
Yeah, their entire job is to patrol the tissue, capture a piece of a threat, and then physically migrate back to the lymph nodes to show it to the T cells and sound the alarm.
So they gather the intel and run back to base.
Precisely. But in these lesions, the exosomes alter the microenvironment so heavily that these dendritic scouts get physically trapped in the dermis, the deeper layer of the skin.
They just get stuck.
They literally fail to migrate. Because the scouts never make it back to base, the body never mounts an adaptive immune response. The host defense network remains completely oblivious.
Okay, let me ask a clarifying question here just to pull the cellular biology and the clinical reality together for everyone listening. If these lesions are building leaky supply lines and they are trapping the immune scouts in the dermis to evade detection, how does the disease timeline actually play out if left totally untreated?
What's fascinating here is the variable natural history of the disease. And that is what makes it so tricky. If you look at untreated VIN across the board, it progresses to invasive cancer in about 9% of cases over a long period, anywhere from 1 to 8 years.
Okay, so it can be quite slow.
It can just sit there simmering. But the critical turning point, the moment the clock speeds up, is the angiogenic switch.
The moment it builds the blood supply.
Exactly. Before the switch, the lesion is stuck at that 1 to 2 millimeter wall, suffocating and trapped. It might sit there for years.
Right.
But once that exosome signaling succeeds and those disorganized leaky blood vessels are established, the timeline accelerates exponentially.
Because now it has fuel.
The lesion suddenly has unlimited fuel. That is exactly why something like DVIN can explode from a tiny cluster of cells into invasive cancer in just 22 months.
So what does this all mean? We have this incredibly grim picture of pre-cancers hijacking the bodybuilding rogue infrastructure, blinding the immune scouts and accelerating toward cancer. It sounds like we are completely outmatched. But based on the translational research in our stack today, the very method they use to hide might be their undoing. The bad news is the body is being hijacked, but the good news is the hijackers are leaving a traceable molecular paper trail that doctors can now detect.
That is the silver lining of this entire biological process. Because these exosomes are so tough, and because they travel so easily throughout the body's fluids, we no longer have to wait for a lesion to grow large enough to be seen with the naked eye or found on a traditional scan. We can catch the saboteurs by intercepting their mail.
Right, through minimally invasive biopsies. Scientists aren't just looking for physical tissue anymore. They are isolating exosomes from simple blood draws or cervicovaginal fluid known as CVF.
And the way they analyze those exosomes has evolved drastically. We aren't just looking for one single random protein to spike. The sources highlight a major move toward network biomarkers.
Oh. How does a network biomarker differ from what we used to do?
Well, cancer is rarely just one single pathway breaking down, right? It is a systemic failure of multiple interconnected systems. So instead of looking for a single red flag, scientists use advanced bioinformatics to look at entire networks of communication.
Okay, that makes sense.
For example, in analyzing cervicovaginal fluid, researchers identified a network biomarker centered around a specific protein called alpha-actinin-4, or ACTN4. When they simply measured the levels of ACTN4 and its associated network in the fluid, it showed an 86% accuracy rate in differentiating healthy tissue from precancerous tissue.
That is incredible. 86% accuracy just from reading the fluid.
Yeah, just from a fluid sample.
You don't have to visually locate a 1 millimeter lesion hidden somewhere in the tissue. You just read the environment. And they are sequencing the RNA inside these captured flash drives too, right?
Exactly. The very same long non-coding RNAs and microRNAs that the tumor is using to bribe the blood vessels are now emerging as our most accurate diagnostic markers.
That's amazing.
High levels of specific exosomal RNA, like one called MEL80T1, for instance, are directly correlated with advancing tumor stage and the risk of metastasis.
Sure.
The tumor's own instructions are betraying it.
If I am fully grasping the magnitude of this, we are talking about a complete paradigm shift in how medicine operates.
Absolutely.
For a century, we've relied on a reactive medical model. We wait for a symptom, we try to visually spot a lesion, and then we try to cut it out. But this research points to a proactive model. We were literally intercepting and translating the microscopic communication of the tumor microenvironment before the lesion even has a chance to flip the angiogenic switch.
It is a profound shift in clinical oncology. We are moving beyond just looking at the physical architecture of the cells. We are listening to their conversations.
Wow.
By analyzing an exosome profile from a simple fluid draw, a doctor could theoretically look at a patient and say, you know, you have a microscopic cluster of cells somewhere in your tissue that is currently suffocating. It is screaming for a blood supply right now. Let's intervene today before they successfully build it.
Which brings us to the ultimate summary of today's deep dive. We started by looking at how perfectly undetectable precancerous lesions, like CIN in the cervix or VIN in the vulva, are trapped by a strict 1 to 2 millimeter growth limit. To survive suffocation, they use exosomes, these tiny, incredibly stable encrypted biological flash drives, to bypass that limit.
Which is just a brilliant survival tactic.
Right. They send corrupted blueprints to local blood vessels, bribing the endothelial cells to build a leaky, disorganized, pothole-filled supply line. And that chaotic highway not only feeds the growing tumor, but poses a massive risk by providing a direct on-ramp for metastasis, all while the immune system scouts are trapped and blinded in the surrounding tissue.
But those same covert messages are giving us the key to early detection through liquid biopsies and network biomarkers. And that leads to one final, truly mind-bending concept for you to mull over as we wrap up today.
Oh, I love these. Lay it on us.
We know from the translational research that the scientific community is already engineering synthetic exosomes in the laboratory.
Synthetic ones, like artificial.
Yeah, that they are designing these artificial lipid bubbles to carry anti-cancer drugs like paclitaxel, delivering them directly to tumors without causing the severe toxicity usually associated with systemic chemotherapy.
Right, because the exosome perfectly protects the payload and can slip right past the body's biological firewalls.
Precisely. So here is the thought I want to leave you with today. If precancers use exosomes to send a build blood vessel signal, and our diagnostic tools can now read and understand that specific signal, could we soon hack the tumor's own communication network?
Oh, wow. You're talking about biological sabotage.
Imagine engineering a synthetic exosome disguised perfectly to match the tumor's own profile, but carrying a Trojan horse payload. Instead of delivering a standard drug, it delivers a specific self-destruct RNA code targeted directly at the very endothelial cells the tumor just corrupted.
So we use their own system against them.
Exactly. We could use the tumor's own private transit system to dismantle the blood supply it just built, literally starving the threat from the inside out before it ever becomes invasive cancer.
Using their own covert highway system against them. That tiny rogue construction crew wouldn't stand a chance. It completely changes how you look at that glowing map of cellular networks. Thank you all for joining us on this deep dive. Keep questioning, keep exploring, and never stop marveling at the incredible hidden mechanics of the human body.